Let's start. Fine. So the discussion today is going to be on mainly on pleural diseases and also a little bit on pulmonary vascular diseases and bronchial carcinoma. Okay. Now these sections are sort of not very commonly, except for pleural disease, of course. The next sections are not very common as MCQs, one or two. So I've just included a few from the other topics. Right. So we start off with pleural diseases, and obviously for an undergraduate level, you need to very well about pleural effusions. Okay. And in this X-ray, you can see this pleural effusion very nicely. And in a chest X-ray, the definition or the description of a pleural effusion is that it is a homogeneous opacity. Homogeneous means it's the same color, same white, okay, which is in comparison with a heterogeneous opacity, which occurs in consolidation, where the whiteness is not that continuous. So the words are homogeneous, heterogeneous. So here in pleural effusion, you will have a homogeneous opacity and you will have an upper meniscal level. Okay, so you have the fluid level like that, right? Like a meniscus. So those are the two things that define a pleural effusion on a chest X-ray. Okay. Now this is obviously very important when you're talking about pleural effusions. Okay, the causes of pleural effusions. Now, as you know, pleural effusions are basically there are two types of pleural effusions. You have exudates and transudates. Okay? And how you differentiate between exudates and transudates is using something called the Light's criteria. Something called the Light's criteria. Now, remember, as you know, exudate means there's a lot of protein in the fluid. Okay, and if this protein is very high, okay, for example, more than 35 grams per liter, you don't really need Light's criteria to make the diagnosis for you. Okay, so what you need to know is if you get a data interpretation question with a pleural fluid protein of more than 35, you don't really need to worry about Light's criteria. Okay, but if it's around 30 or if it's sort of borderline, then you might need Light's criteria to make the differentiation. So main message, pleural protein very high, above 35, don't worry about doing anything else. You have the answer there, that is probably an exudate. But if it's somewhere between 30 to 35, then you might need Light's criteria to make the diagnosis for you. And in this slide, I have given you Light's criteria, and you need to know what the parameters are. So as you can see, pleural fluid protein to serum protein more than 0.5, then comparison of the pleural fluid LDH to the serum LDH, and then also pleural fluid LDH more than 2/3 upper limit of normal serum LDH. And one or more of these would define an exudate. Now on the right hand side of this slide, I have also included something called the modified Light's criteria. It is essentially the same, but there are few changes. So this is for your reference. If you like, you can just remember these other two slightly more modified Light's criteria. But for undergraduate, table 1 is what is more important. The image on the left side is what is more important. But there's something called a modified Light's criteria, which is used in further difficult differentiations. Okay, so but don't worry about this, just for your reference. This is what is important for you as a medical student to know the 3 criteria which is in their Light's criteria. But remember, if the pleural fluid protein is very high, then you don't need Light's criteria. You can just label it as exudate. Okay. Hari. Now, these are very common questions. What are the causes of exudative effusions? What are the causes of transudative effusions? So you need to remember some lists. So in this slide show, I have given you, in this presentation, I have given you some lists. Okay. So obviously, I'm not going to go through all of these things, but in your free time, and especially when you're preparing for the exam, the day before the exam, these are some tables that you need to go through. Okay. Now, some are obvious. You know that transudates are most often due to organ failure related problems. Okay. And low albumin. But remember, there are some unusual causes of transudates. Less common causes. Okay. Less common causes. So, ones can appear in your MCQs. Okay. Now, for example, something like pulmonary embolus can be transudative. So if there is a worded MCQ like that, an effusion associated with pulmonary embolus can be transudative. And there are some other classical MCQ related ones which you need to know about. Meigs syndrome, okay, which is something that occurs in ovarian carcinoma, sometimes even in benign tumors. So these are transudative, okay. And on the other side, exudative, there are a whole range of causes. Okay, whole range of causes. So some of the unusual ones might appear in your MCQ paper. And obviously, all of you should be able to answer this without a problem. Okay, so this list is important. Now, similarly, this next table is also important. Okay, it gives you some of the characteristics of the pleural effusions that you see. Okay, the appearance. Okay, and I especially would draw your attention to the causes of hemorrhagic effusion. Causes of hemorrhagic effusion. Again, another important MCQ topic. Okay, cause of hemorrhagic pleural effusion, and may list you need to add SLE pleuritis related pleural effusion can also be hemorrhagic. Make anittevatik okkom wage tiyenawa. The thing that's not there is a SLE pleuritis related pleural effusion that can also be hemorrhagic. And also you need to go through some of the characteristics of the pleural effusions in this table. Okay, fine. Now this is something a bit more descriptive, and I draw your attention to the three things. You need to know the causes of pleural effusions with low glucose, okay? Pleural fluid with low pH less than 7.2, and we already discussed one of this last week, complicated parapneumonic effusion and empyema. And there are some other causes of pH less than 7.2. Forget what this odd thing is, don't worry about this. Paragonimasis or whatever, don't worry, that's an infection. So pH less than 7.2 and elevated amylase. As you can see, esophageal rupture, pancreatitis, related effusions can have elevated amylase. So these points can appear in your MCQ. I know this is just by heart stuff, okay? But in the exam, we do ask you some by heart stuff. So for pleural effusions, remember you will have these three tables are important, okay? First of all, causes, transudate, exudate. Then appearances of various types of pleural effusions, and also pleural effusions with a low glucose, pleural effusions with a low pH less than 7.2, and pleural effusions with a high amylase. So, you need to be aware of, and are definitely asked in a MCQ. And here I have given some of them, question 2. So you can answer these with the lists that I have given. Right. So remember, when you're preparing for the exam, remember I told you that we'll continue these sessions right up to your exam or during your study leave as well. You need to have a collection of these lists before you go for the exam. So the last day of preparation, you need usually medicine on the first day. So Sunday, you will be having a set of lists to go through. And one of the important lists are these things of pleural effusion related things. So that's why I told you I'm going to give you some important slides that you need to write down and maintain in your notes somewhere just to revise before the exam. Okay? And these are very common questions. Right, now a few other things about pleural effusion in this third question. The first thing is bronchial breathing may be detected along the upper margin of a pleural effusion. Now that is correct. You can detect bronchial breathing above the upper margin of the pleural effusion. Now obviously you know the other features of pleural effusion very well. Okay, the characteristic sign, if you were to select one sign characteristic of a pleural effusion, that would be stony dullness on percussion, which if you have gone through clinical work with us, you will know that is different from just plain dullness. Okay, so stony dullness is different. And if you don't know the difference, I will teach you when you start. I think I've already taught you this during your pre-professorial times. So bronchial breathing is detected along the upper margin of effusion, which is true. The second question is about how much fluid you can detect on a chest X-ray. Now, the first thing you need to remember is, one, it depends on the type of film you're looking at. Now, if you take a standard posterior anterior film, you need at least 300 to 500 ml, at least 300 ml. So that's a range, you give a range, 300 to 500 ml of fluid to detect it on the chest X-ray. That is posterior anterior. Now, if you take a lateral film, or those days we used to say, take something called a lateral decubitus view, which we very, very rarely do nowadays. And the reason is because you have ultrasound now, okay? We used to do something called a lateral decubitus X-ray long time ago for dengue effusions, okay? But we don't do that anymore. I don't know whether they do it in pediatrics, but because it's ultrasound scan now, we don't use that anymore, okay? So if you take a lateral view or a lateral decubitus view, you might be able to detect 100 to 150 cc or something like that, okay? And definitely this statement is wrong. You can't detect pleural effusions of 50 ml on a chest X-ray piece. The usual standard cutoff you would detect is around 300 to 500 cc. But you might be able to detect 50 ml on an ultrasound scan. So ultrasound scan, it's usually 30 to 50 ml is the cutoff. Okay? You should be able to detect something between 30 ml to 50 ml on an ultrasound scan. Ultrasound scan 50, around 100 you can detect lateral and decubitus, but on the PHS X-ray, standard PHS X-ray, it's about 300, 500 ml. I don't know, it's a frequent, you can frequently detect this on
yes sir. So chutta connection එක මේ පොඩ්ඩක් එහෙම break කරනවා.
oh audio එක Netflix බලනවද මේ හොඳට මෞලිකව කියන්න.
නෑ සර් එච්චර ප්‍රශ්න නෑ සර්.
Okay, right. Fine. So chest X-ray PA can detect pleural effusion. Now the third statement also we discussed last week, encysted and septated pleural effusions occurring as a complication of pneumonia do not require aspiration is wrong. It's a blanket statement. And you need to think about this effusion. Aspirate, or something I told you last week that you need to surgically go in and take the adhesions. Okay, so these are this statement wrong. Septated and encysted pleural effusions are complicated pleural effusions, and most of the time they turn into complications. So the third statement is false because they often do need to be aspirated, but aspiration sometimes can't get the fluid out, so you need to go in surgically and drain it out. Fourth statement we have already discussed. So pleural effusions with low pleural fluid glucose less than 60 you see in rheumatoid arthritis. Also, and another additional thing is again SLE related pleural effusion. So you can see low glucose levels. Obliteration of the pleural space is a therapeutic option for people with recurrent effusions. Now, this is true if you get a recurrent pleural effusion, okay, due to whatever cause, okay. You can insert some substances, sometimes you use talc, okay, and that sort of pastes the pleura together, okay, various substances, various chemicals. When you put it into the pleural fluid, the pleura gets stuck together, and that prevents pleural effusions from occurring, okay. So this is a sort of last option for people with recurrent pleural effusions. Okay, recurrent pleural effusions, you can insert something like talc, where it pastes the pleura together. Okay, so that is something that we do. Okay. Now, these are two nice examples in these pictures. Can you see this is a ultrasound scan, and you can see the lot of adhesions. The pleural effusion again. This is the lung, and this is the fluid, and you can see a lot of adhesions. These white streaks are adhesions and septations. So this is a very complex pleural effusion, one of these empyema-like ones. And even on this right side, you can see a very complex pleural effusion with lot of septations. Okay, with a lot of septations. Right, now moving on to the next topic. As you can see, this chest X-ray shows a pneumothorax. Okay, On the left side, you can see the pneumothorax, and you can see very nicely the lung margin. If you follow my mouse pointer, you can see the collapsed lung, okay, with the pneumothorax on the left side. Now, regarding pneumothorax, there are 5 MCQs here. And remember, the first MCQ, is focusing on this, the causes of pneumothorax. So again, one of these lists that you need to be familiar with. Okay, what are pneumothorax? Now, pneumothorax can be primary spontaneous. Primary spontaneous. The lungs, underlying lungs, are structurally, generally, don't have any other secondary disease. Okay, there are lots of other secondary diseases that you're thinking of. When you get a pneumothorax, there might be secondary diseases. And any person who does not have any of these secondary diseases, we classify them as primary spontaneous pneumothorax. So just go through the list, and some of the answers to the MCQ are in the list. I go back to the MCQ now. So so pneumothorax classification will be primary, secondary. Secondary, there is a disease process in the lungs that trigger the pneumothorax. Primary, you are just walking, perfectly healthy person, it's a pneumothorax. And primary spontaneous pneumothorax is much more common in males, specifically tall males. Okay, and that is probably because of some of the pressure differences in the lung. Okay, so tall males are primary spontaneous pneumothorax. Make a female, female. So this says female, so that's wrong. So it's commoner in males. Pneumothorax is a recognized complication of pneumocystis jirovecii or pneumocystis carinii infection, which is again right. Okay, that's correct. We'll talk again about this when you're talking about HIV. Now, as you know, pneumocystis jirovecii was the defining illness, or we call this an AIDS defining illness. And that's how they discovered HIV in New York, based on these infections, where they found that homosexual men began to die with a very severe pneumonia. And there's a lot of history with pneumocystis jirovecii and HIV. Now, one of the complications of pneumocystis jirovecii in the lung is it causes multiple cysts, air-filled pockets in the lungs. So as you can imagine, these air pockets rupture and cause pneumothorax. Okay, so therefore, pneumothorax is a recognized complication. Hari. Now, the next one, I went through some of your answers. You didn't answer this one, right? Obviously, because you don't know properly. So, can you diagnose a pneumothorax on an ultrasound scan? Now, ultrasound scan is becoming very, very popular nowadays for emergencies, because you can actually use it at the bedside. If you have a machine, X-ray volta, you don't need to get the attendant to come and take the patient to X-ray and wait outside the X-ray room and call the bloody X-ray in-ward people who never work. That sort of thing you don't need to do if you have an ultrasound scan. And in most wards now, you have ultrasound scans. And remember, pneumothorax is one of the diseases that you can diagnose with an ultrasound scan. Like a Pulmonary, you can diagnose it. And if you know ultrasound, there is something called M mode. You get something called M mode. M mode, you see something like this. It's called a barcode sign. Lung ultrasound machine, you get an appearance like this. It's called a barcode. As you can see, the analogy is with the barcode. And then, when you use an ultrasound scan for the lung, this is the pleura. You can see marked on this slide, pleural line. You will see when the patient breathes, this line moving. Okay, my line move up and down. It moves like this. The pleural line moves. In a pneumothorax, this stops moving. Okay, this stops moving. So these are the two changes you see in the ultrasound scan in pneumothorax. Okay, so barcode sign and the pleural line does not move. That's also called lung sliding. Lung sliding, a movement called. So there is no lung sliding in ultrasound scan when you get a pneumothorax. So you need to be aware that you can diagnose a pneumothorax on an ultrasound scan of the chest, okay, based on these two signs. Now, the next two questions are based on the management of pneumothorax. Now, when you're talking about management of pneumothorax, estimation of size is very important. මේක ගොඩක් අය දන්නේ නැහැ. So you need to know about this. අහනවා. Even in a Viva, they might ask you. Now, there are two ways to estimate size on a X-ray of a pneumothorax. Depends where you are. For example, if you're in America, you measure it like this. Okay, I can watch my mouse pointer. You measure it like this. Okay, A කියලා ගහලා තියෙන එක. In England, if you are in England, you measure it from the hilum, and that is mostly standard practice. Hilum එකකින් නම් measure කරන එක. හරි, hilum එකකින් නම් measure කරන එක. That is standard practice. A significant pneumothorax is 3 centimeters if A, simple A, is more than 3 centimeters, or if B is more than 2 centimeters. So those are the two values. Now, most of the time, api පාවිච්චි කරන්නේ UK guidelines, so we can take the 2 centimeter thing as our cutoff. Okay. So this is how you manage a spontaneous pneumothorax. Now, remember, traumatic pneumothorax, the management is different, and they'll teach you in the trauma module, or they've already taught you in the trauma module, whatever about this. But here we are talking just about spontaneous pneumothorax. You have primary spontaneous and secondary pneumothorax. Okay, and this flow chart gives you an idea of how to manage. Okay, how to manage. So if it's a primary pneumothorax, if it's more than 2 centimeters and or breathless, you first try aspirating the effusion. Okay, aspirate the effusion. And if the patient improves and the shrinks in size, that less than 2 centimeters, now you can discharge. Okay, but if it doesn't improve, then you have to insert a chest drain. Then you have to insert a chest drain. Right? So that's how you manage a primary spontaneous pneumothorax. Now we'll do this again next week with a proper case scenario. I told you we're talking about emergencies next week, and we'll discuss the secondary ones in more detail. But for the purpose of this MCQ, okay, a primary spontaneous pneumothorax with a rim of air of 4 centimeters at the hilum can be managed conservatively. So let's go back to this. I'm not going to talk about secondary ones today. I'm going to talk about that next week. Today we are going to talk about just the primary people. So primary spontaneous pneumothorax, the basis is size more than 2 centimeters and or breathless. Okay. Aspirate and repeat the chest X-ray and see if the patient clinically improves. So patient clinically better and the rim has reduced to less than 2 centimeters, you can discharge the patient. Okay. ලංකාවේ නම් එකපාරට discharge කරන්නේ නැහැ. We observe for 24 hours. Okay, usually. Now, the algorithm. Right? Now, if a patient comes to you, best of 5 බලහනවා. Just a 1 centimeter ring, primary spontaneous pneumothorax, no symptoms at all, you can actually discharge the person. Okay, that's what it says. Consider discharge. Consider කියලා කියන්නේ. So you have ලංකාවේ you do it a bit differently. ලෙඩ ආපු ගමන් pneumothorax එකක් තිබ්බ අපි ගෙදර යවන්නේ නැහැ, but you can consider discharge. So best of 5 FCQ එක ඇහුවොත් එහෙම you need to know these cutoffs. So the important thing is we are measuring the pneumothorax from the hilum to the pneumothorax. It is 2 centimeters. තමයි significant. By the way, if you are going to America, the way they measure is a bit different. That is from the top to the apex of the lung. It is 3 centimeters if you are using that. So here 4 centimeters, in this MCQ, it is significant. And you cannot manage that conservatively. So remember, more than anything, or rest of the size. If the patient is breathless, then you need to intervene. Okay, so may this box that I'm circling with my mouse pointer is what is important. Okay, Hari. I hope that's clear. Needle aspiration is contraindicated in a patient with a secondary pneumothorax, and we'll come to that next week. But remember, you can find the answer from this algorithm for your own. Okay, right. I'm not talking about secondary because I'll probably give you a case next week about secondary pneumothorax, secondary spontaneous pneumothorax. Okay. So that's about pleural disease. So we have discussed pleural effusion and pneumothorax. Any questions, please put it on the chat. Okay. And also, just to remind you, because today is the last day of respiratory medicine, if there are any sort of past paper questions that you need regarding respiratory medicine, you can also put it on the chat. Okay. Then I will answer as we go on or at the end of the session. I have answered most of your queries on the group itself, but if you have anything else to ask, you can put it on the group. Okay, chat. Right, now moving on to pulmonary embolism. Okay, now this is again a more of an emergency medicine topic, which we'll revisit next week, right? But we just go through the principles of pulmonary embolism today. Now we start off with, obviously all of you have to know the causes for pulmonary embolism, and that is this the common causes. Okay, one of the common important causes are malignancy. You have to know that. So active malignancy or even treated malignancy can increase your risk of pulmonary embolism. Okay. The other thing that we very commonly see is immobilization following lower limb or pelvic fractures. Okay, immobilization following lower limb or pelvic fractures. These are two of the commonest causes of pulmonary embolism. Okay. And also, you need to remember that pulmonary embolism is far commoner in the Caucasian or the Western populations when compared to Asian populations. Okay, so the difference in incidence is probably there's some genetic thing going on. If you take where I practice, they think of pulmonary embolism for almost everything because the incidence is high, and they do some stupid things also. That is a different matter. But the incidence is much higher in the West and the Caucasian or European population, and maybe in the US as well, compared to Asia. Okay, probably something genetic involved. And you need to know the causes. There are rare causes, but the commonest causes are malignancy, active and treated malignancy, as well as lower limb pelvic fractures and immobilization. Very, very common. Okay. Now, what are the symptoms of pulmonary embolism? You don't have to go through this in detail. Okay, you don't have to go through this in detail. But syncope is a very important feature of a large pulmonary embolism. When it's a large pulmonary embolism, you present with syncope. Okay, and the reason for that is, okay, when there is an acute PE causing pulmonary vascular obstruction, there is a sudden increase in the right ventricular afterload. Kapata right has a massive pressure to pump against. And if you remember our cardiology discussions about the septum, I obviously told you that if you take the interventricular septum, when there is a sudden increase on the right ventricular pressure, if you remember me telling you, the septum, the interventricular septum gets pushed onto the left side. Okay, it gets pushed onto the left side, and that decreases the stroke volume on the left heart, and that causes a drop in the blood pressure and syncope. Okay, that causes a drop in the blood pressure and syncope. And there are also other mechanisms. This particular figure is a bit too complicated for you, but again, if you like, you can read and try to understand the mechanisms that are involved in a pulmonary embolism. Okay, but remember, the main reason why it causes syncope when it's a large PE, because it blocks the right ventricular outflow, increasing the right ventricular pressure and afterload, and that pushes the interventricular septum onto the left side, compromising the cardiac output on the left heart, and that causes a syncope. Okay, and also there are other reasons for syncope like hypoxia, and they might get arrhythmias. So those are the three causes for syncope in a large pulmonary embolism. Okay, so it's well known to present with syncope, and incidentally, this is one of Pandukas's favorite questions if he asks about pulmonary embolism, right? He actually asked one of the postgraduates one day and was really angry that they didn't know this. So remember, syncope is a very important feature of a large P. Okay, so they get the right ventricular pressure increases, the septum is deviated, hypoxia, and sometimes people get arrhythmias as well because of the strain on the right heart. Now, that's a large P. Okay, If it's a smaller PE, they, especially if it's closer to the pleura, they get wedge-shaped pulmonary infarctions very commonly, and that causes a pleuritic type chest pain. Okay, wedge-shaped pulmonary infarctions, pleuritic type chest pain, and hemoptysis. So generally, api kiyanawa, if the patient has pleuritic chest pain, hemoptysis, it's probably a peripheral PE. Okay, peripheral PE, because it causes a pulmonary infarct, a wedge-shaped pulmonary infarct. But if it's a massive PE right in the middle of the pulmonary trunk, okay, sometimes you call it a saddle PE, then you get syncope as your main manifestation. And I have personally seen cases who have come with syncope who ended up having a pulmonary embolism. Okay, it's very important. I had a person in England who came with there was no shortness of breath. Very interesting presentation. Shortness of breath patient. The patient had collapsed 4 times in the garage and came in. When we measured the saturation, it was about 89%. And this was a patient without pre-existing lung disease, right? COPD. So we thought, why is the saturation low? There's no reason for the saturation to be low. And when you did the CTPA, the patient massive PE in the middle, right in the pulmonary trunk. So these are some stories for you to remember that syncope is a very important presentation. Right. Now this you have to know again. Just run this by you and through your heads and just familiarize yourself to the Wells criteria for diagnosis of PE. And as you can see, previous PE, okay, cancer, recent surgery, immobilization increase the risk of PE from the Wells criteria. So this criteria is what we use to assess the probability of PE. Probability of PE. And it is also called the pre-test probability because based on the Wells score, you select your test, what you do. Okay. Now I'll come to that next. So look at the Wells criteria again. Now, based on the pre-test probability, the test you select changes. If you have a very high probability of PE from the Wells criteria or clinical Wells criteria, clinically, for example, you have a patient with cancer coming with massive shortness of breath, you have a very high probability of PE. If you have a very high probability of PE, then there is no point in just directly go for the gold standard investigation. That is the CTPA. Now, in some books, they also give you VQ scan as a gold standard. But remember that in practice, we take. The problem is that VQ scan, it's called a ventilation perfusion scan. At Oxford, unfortunately, they do only the perfusion. Okay. So if the patient has a lung disease affecting ventilation, perfusion when you have a low area of low ventilation, the perfusion is also automatically reduced, physiologically reduced. So when just the perfusion in a patient with underlying lung disease, remember underlying lung disease, if they have already ventilation problems, you will get perfusion defects which are false positives. So I'll explain that again. In the ventilation perfusion scan, you measure paired both ventilation and perfusion together. Now, if in countries, in most centers, Lanka with they because the ventilation scan is difficult to do, they do the perfusion scan only. So perfusion scan only karamatina prasne mokadda, because if the patient has underlying lung ventilation problems chronically, okay, or for example, they have a pneumonia and you're thinking of a pulmonary embolism in a patient with a pneumonia. Now, because the area of the lung is abnormal and the ventilation is affected, automatically the perfusion is reduced to that area. That is a normal response. So that will appear as false positive perfusion defects. on the perfusion scan. So it is not used as a gold standard. We sometimes use it in pregnancy and sort of young females in the pregnant age group. But the important thing to remember is you should exclude a structural or lung problem. Again, a ventilation problem should be excluded. Okay, ventilation problem should be excluded if you are doing a perfusion scan. So the gold standard is a TPA. Nipun, yes, Geneva score is also used for diagnosis of PE, but commonly we use the Bell score because it's a bit easier. We use the Bell score, but yes, you're right, Geneva score is also used. So yes, so we're talking about the Bell score. If they have a high probability of PE, then you go for directly for a CTPA test. Okay, not a ventilation perfusion scan. You go for directly for a CTPA. If they have a low probability and you just want to exclude a PE, they have a low probability clinically, apne sure naha meka wennat puluwan nathi wennat puluwan. If you are using the patient has a low probability, then the test is a D-dimer test. So why do we do that? Because the D-dimer has a very good negative predictive value. If the D-dimer is negative, you can forget about the diagnosis of PE. Okay. But if it's positive, it can be positive in a lot of other conditions. Any thrombus anywhere will cause a positive D-dimer. Sepsis, positive D-dimer. Anything, renal impairment can cause a positive D-dimer. Okay, so D-dimer, there are lots of causes for it to go up. But it has a very good, so underline that statement, it has a very good negative predictive value. So if it's negative, then you can exclude P. So in a low probability, apita make exclude karagannat one kiyanakota, then you can do the D-dimer. If it's negative, then you're quite sure that it is not a P. But if it's positive, you end up doing a CTPA anyway. Okay, because positive nang, you can't say mokadda kiyala haritama kiyanna. Right. Now remember that the level does the D-dimer level predict the probability of CTPA? There are some recent studies that do show that very high D-dimers are supportive of PE, but only a few studies. Right? So godak high nang, so for example, if it's very, very high, okay, it increases the probability of PE. Okay. Okay. Fine. D-dimer samanya cutoffs ganne about 1000. Usually cutoffs are about 500 to 600. If it's more than 1000, then we get a bit serious about it. If it's about 6000, 7000, it increases the probability of P. But a positive D-dimer confirms the diagnosis is completely wrong because it can be elevated in other conditions as well. Okay. So that is not a gold standard. It is for exclusion. If it's negative, then you can exclude it. Right. Okay. So Well score. And this MCQ, best of 5 MCQ also, we are talking about a PE here. Patient with ovarian cancer, desaturating, lungs clear, tachycardia, right bundle branch block, everything recipe for pulmonary embolism, chest X-ray is clear. Okay. Chest X-ray is clear, then you can obviously think that this is a very high probability of a PE, so therefore you need to directly go for a CTPA. No D-dimers in this condition. No D-dimers. You can directly go for a CTPA. Okay. Method VQ scan tibbana, what will you select? Again, you will select a CTPA. In this best of 5 response, if it was a young female or sort of reproductive age group female or pregnancy or something like that, then if you had the choice, okay, then you might select VQ scan. But the important thing is VQ scan you can interpret in this patient because the chest X-ray is normal. Right? I told you that the chest X-ray should be normal for you to be able to interpret a VQ scan because we only do the perfusion part of it. So if this same MCQ was given as a sort of 23-year-old reproductive age group, something, then you can consider a VQ scan. Okay, so that's some because you get confused. But usually, most of the time, CTPA is the gold standard. But in a sort of young female reproductive age group pregnancy, we might still consider doing a VQ scan. But remember, very, very importantly, because we do the perfusion only, you need to have a normal chest X-ray, normal lungs, and normal ventilation to do the or interpret the perfusion scan. Okay, that's fine. So now a little few other things. ECG. What are the ECG changes that occur in a pulmonary embolism? This famous S1. So you can see a S wave there, Q wave, and a T inversion. So this is S1, Q3, T3 pattern on the ECG. And also you can see ST depressions and T inversions, and a very prominent right ventricular ECG. Okay, usually positive when V1 to V3, usually the waves are negative. And this is also called poor R wave progression. Okay, so in this patient, there is S1, Q3, T3, and this is what you call right ventricular strain. This is what you call right ventricular strain. So what might you get? Because of the pressure and stress on the right ventricle, you get ST depressions, T inversions, and sometimes even right bundle branch blocks. Okay, right bundle branch blocks. So these are some of the ECG changes you will see in a PE. Very important. ECG commonly shows S1, Q3, T3 pattern is wrong. The ECG commonly shows is just sinus tachycardia. So commonly Q1 is a parallel. S1, Q3, T3 is a nice pattern on ECG, but it is a rare pattern on ECG. It is not a common pattern. The common pattern is sinus tachycardia and next right ventricular strain, like right bundle branch block, ST depressions and T inversions. So that is also commonly kiyapu nisa meka waradi. Commonly kiyapu nisa. Now we will again do this next week when you're talking about emergencies. But how do you manage a PE? Now this again might be useful for you to just see. Again, this is something called the PESI score. PESI. 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 PESI score. And this basically predicts the mortality from PE. But if somebody asks the PESI score predicts the mortality of PE, yes, it gives you the mortality risk. And you can see points. You can't obviously remember all of this, but this predicts the mortality. So now you know two scores for PE. One is a Wells score or the Geneva score, which is used for diagnosis. PESI, PESI score is used for the prognostication to determine the mortality risk. Mortality risk. Okay. Right. How do you manage PE? People who are hemodynamically stable. We'll talk about this next week. Hemodynamically stable, you anticoagulate them. Okay. This can be done usually with heparin anticoagulation. So people who are stable can be given a anticoagulation strategy. Low molecular weight heparin is the treatment of choice. Okay. If the patient is hemodynamically unstable, okay, and as you can see, that carries a very high mortality risk, systolic blood pressure less than 100. Then you need to use thrombolysis. So thrombolysis is contraindicated if the patient is hemodynamically unstable clinically. It's the wrong statement, but that is the treatment if the patient is hemodynamically unstable. So again, to summarize, we'll talk about this more next week in a emergency session with the best of 5 questions we did for cardiology. But basically, your patient stable now be very simplistic. If the patient is stable, then you anticoagulate with heparin. If the patient is unstable, then your primary treatment of choice is thrombolysis. And thrombolysis is with streptokinase. Okay, this is one of the places where you use streptokinase. And some people have used LTPS as well. Streptokinase or Helictyplase, there are some trials, but I don't think it's in wide use. So altiplase or streptokinase are the two things that we use. So PESI score, mortality risk. Okay. And yeah, and the Wells score is diagnosis. Now there are some other interesting things. Some people ask you mainly at Vivas. There are certain chest X-ray signs that you can get in pulmonary embolism. These are very, very rare. So if I was setting a paper, I would never ask these, but some people like to ask this. Okay. Okay. This Hampton's hump basically that is this sort of thing, a wedge-shaped pulmonary infarct. So that is called Hampton's hump. Westermarck sign is basically peripheral oligemia, and you can't see this here, a prominent sort of pulmonary vein cutoff there. Sorry, pulmonary artery cutoff. If you know Hampton's hump, that's more than enough. Okay, and this Fleischner sign is again a rare thing, a very prominent pulmonary artery in peripheral oligemia. Again, the peripheral arteries are very small, but a very large pulmonary artery in the. Not very important, just for your interest. But Hampton's hump, remember, they might ask you, right? A wedge-shaped pulmonary infarct. Westermarck sign is basically peripheral oligemia, because the pulmonary arterial circulation is cut off. You get oligemia in the periphery of the lung. And this CT scan shows a very large pulmonary embolism. Okay, there the that's the pulmonary embolism. A gray color, you can see the pulmonary embolism, and that is a massive or a saddle pulmonary embolism. Saddle pulmonary embolism. And you can see a lot of methanat, this thing is also P. So this patient is basically, the patient is going to present definitely with syncope and low blood pressure because of massive stress on the right arm. Okay. Now we are going to again a rather uncommon topic. I've just included one MCQ on this. Pulmonary hypertension. Now this again is a very, before we go to Samira, are there contraindications to CTPN? Well, the usual contraindications can in contrast allergy. You can take those as contraindications. Or pregnancy, those sort of things, take by even in pregnancy, you can still do it if you think it's very indicated. Right? But may definitely contrast allergy. Contrast allergy you can't do CTPN. Okay. Right, so this is an uncommon topic. You just need to know the very, very basics of this. Already you know 3 answers to this. Pulmonary hypertension, the second, third and fourth statements you will know how to answer. Okay. And in pulmonary hypertension, the physical signs also you need to know. What are the physical signs? Pulmonary hypertension. If you don't know, write this down. So the physical signs you know would be a palpable, loud second heart sound in the pulmonary area. Physical sign, good physical sign. Okay. Then you would also get a right ventricular heave, because right ventricular NAI, when there is pulmonary hypertension, you get a prominent right ventricular heave because of right ventricular hypertrophy. Okay. So palpable, loud second heart sound, right ventricular heave are 2 important physical signs that you would see. And also in the neck, jugular venous pressure, okay? And if secondarily, you can get tricuspid regurgitation. Heart failure, when there is pulmonary hypertension progressing, the right heart begins to dilate and fail. Then you get functional tricuspid regurgitation. Functional tricuspid regurgitation. So any physical sign with features of tricuspid regurgitation also you are going to get in a patient with pulmonary hypertension. Your loud palpable second heart sound, parasternal heave, elevated JVP, especially the A wave will be elevated in the JVP. Then your features of tricuspid regurgitation, which I have taught you. Okay, so that is one thing that you already know. And then that bundle branch block would be a feature. The other thing you see in the ECG is a P pulmonale. Okay, a peaked P wave, P pulmonale. Elevated BNP's diagnostic diagnostic, it is elevated in anything that causes heart failure. So it's not diagnostic. And chest X-ray, you will see a very prominent pulmonary hilum. You can see the very nice pulmonary arteries. And as you go laterally, the pulmonary arteries get smaller. Okay? But when you get peripherally, they get smaller and less obvious. This is called pruning. Pruning. P-R-U-N-I-N-G. Pruning can you gas hema kapanne me wateyata kapanne prune කරනවා කියලා කියන්නේ. If you know gardening, දේශවල ඔයගොල්ලෝ මොකද ගෙවතු වගා සංග්‍රාමයේද මොකද කරනවා? You know what pruning is. Okay? Pruning is you peripherally you cut the plant to make a nice shape or wateyata එන quality කපන එක. So like that, you see a very prominent pulmonary hilum and it sort of reduces in size as you go more peripherally or laterally. So that is called peripheral pruning. These are some chest X-rays changes. So plethoric lung fields in the head, plethoric lung fields in the head because there's peripheral pruning. You get peripheral origin. Hi. Now, this is again a long list of causes of pulmonary hypertension. Hari? Not very important, but nikang uding balanna. So pulmonary hypertension is there's pulmonary arterial hypertension. Okay. And then you have pulmonary hypertension due to left heart disease, pulmonary hypertension due to lung disease, thromboembolic pulmonary hypertension, and a useless thing called multifactorial pulmonary hypertension. A whole lot of list causes. This is a specialist topic, so you don't need to know a lot about this. But just go through these causes. So pulmonary arterial hypertension, there is a disease of the pulmonary artery itself. Okay, usually pulmonary artery gets blocked with time. Then you get obviously pulmonary hypertension due to heart disease, mitral stenosis, VSD, you get that. Then you get lung disease, copulmonary. Okay, so you get a lot of causes. And remember that endothelin receptor antagonist, the example is bosentan, or things like sildenafil, which is a phosphodiesterase inhibitor, would be used in the management because it causes pulmonary vasodilation. Calcium channel blockers are also used. Okay. Calcium gimphanias, so left to right shunts also cause pulmonary hypertension. Eka me classification එකේ ගොඩක් කරලා මෙන්න මෙතන මේ heart disease කියන තැනට තමයි දාන්නේ. Okay. Yes. So two drugs that are used is endothelin receptor antagonists and things like sildenafil because it causes pulmonary vasodilatation. The other type of drug we use is a calcium channel blocker. Another MCQ point that you might need to write down here is that the diagnosis of pulmonary hypertension gold standard is you need to put a catheter into the right heart. Right? That's called a right heart cardiac catheterization. So to make a definitive diagnosis of pulmonary hypertension, you need to put a catheter into the pulmonary artery through the right heart. That is a definitive diagnosis. But you can estimate, the words I'm using are important, you can estimate the pulmonary pressure with an echocardiogram. You can estimate the pulmonary pressure with echocardiogram. But the goals, if somebody asks you an MCQ, gold standard of diagnosis of pulmonary hypertension is you need to put a cardiac catheterization. In pediatrics, you would have encountered this. You put a catheter into the heart and directly measure the pulmonary pressure. Okay, so that's a gold standard of diagnosis. Ignore this slide. This is just a management. Don't worry about that. A little thing. I told you that the gold standard diagnosis is through catheterization of the right heart. I told you that's a gold standard diagnosis. Okay. The gold standard diagnosis is catheterization of the right heart. What they do is they put that catheter and put a vasodilatory substance into the pulmonary artery to see if the pulmonary artery vasodilates. So this is a little bit more, but MCQ, I can remember somewhere they have asked. So you put a catheter into the pulmonary artery, put something to dilate the artery. Okay, put something in to dilate the artery. If it dilates well, patient is going to respond very well to calcium channel blockers. So you can write that down. So a good vasodilated response on angiography, okay, calcium channel blockers are used. If they don't vasodilate, so just imagine you put something into the pulmonary artery, use something into the pulmonary artery when you're catheterizing it, and then if it dilates well, that means it will respond very well to calcium channel blockers like nifedipine. So then you use nifedipine. That's the ideal way for management. If it doesn't dilate, then use the sildenafil or other drugs like Bosentan. Vajira, I don't know. So you don't need to know how to interpret cardiac catheterization reports for medicine. I don't know for pediatrics whether you'll be asked, but for medicine, definitely no. Can you use inhaled NO? Yes, inhaled NO is also used in the management sometimes because it's sort of vasodilated, but that's mostly the acute setting. Right. So don't worry a lot about pulmonary hypertension. It's not a common topic, but you need to know the physical signs, ECG changes, X-ray changes. And I'm sorry, I forgot to answer the first MCQ. Yes, pulmonary arterial hypertension, when a maker, is commoner in females. Pulmonary arterial hypertension is common in females. And all these managements are for pulmonary arterial hypertension. If it's a heart failure, heart disease, you correct the heart disease, valve replacement or whatever. Try to do that. So for pulmonary arterial hypertension, the management is with these drugs, calcium channel blockers or this phosphodiesterase or endotagonists. Some other drugs which you don't have in Sri Lanka, like prostaglandin infusion and things. Okay, now this is easy. Easy MCQ. I think all of you had answered this properly, should have answered this properly. At least you already know that the answers, true ones, are exudative pleural effusion could favor a diagnosis of bronchial carcinoma. And the one that you might wish off is proximal myopathy. How does bronchial carcinoma? That is a paraneoplastic syndrome, because you know that some bronchial malignancies, especially the, write this down, small cell carcinoma, those can cause Cushing syndrome and ectopic ACTH secretion. Okay? So that can cause proximal muscle weakness. This is a very nice picture of a patient with some of the complications of bronchial carcinoma. And here you can see the cancer is occluding the superior vena cava, okay, completely blocking it out, okay. And you can see this is called SVC obstruction, with red face, neck veins dilated, fixed and dilated, okay. So you see a lot of, this is SVC obstruction, a picture of SVC obstruction. Right, this is called hypertrophic pulmonary osteoarthropathy, MCQ tibuna, right? So you see clubbing and also a lot of soft tissue enlargement. X-ray, can you see this? This soft tissue, this whitish thing is the soft tissue enlargement that you see in HPOA. So HPOA is a very severe form of clubbing where you get a lot of soft tissue enlargement as well. And if you look at the, X-ray on this side, X-ray on this side, can you see two lines here? X-ray line, watch my mouse pointer, there is a line going like that and a line going like that. So this is called a periosteal reaction, which is a very nice feature that you see in a patient with HPOA. So if somebody gives you an X-ray of HPOA to identify an OSCE or something, which is I think very unfair for a medical student, but so basically you have soft tissue enlargement on the X-ray and this periosteal reaction. Two lines, you can see periosteal reaction. One line, two lines, periosteal reaction. Right? This is, what is this? Pancoast syndrome, apical lung tumor, and with Horner's syndrome and small muscle wasting. Okay, so these are some pictures for you to remember to identify. So we have answered this MCQ. What are the following features of or suggestive of a diagnosis of bronchial carcinoma? Exudative pleural effusion, small muscle wasting, which is basically Pancoast syndrome, Hypertrophic pulmonary osteoarthropathy occurs mostly in squamous cell cancer. Squamous cell cancer. So I have shown you an X-ray hypertrophic pulmonary osteoarthropathy with soft tissue swelling of the fingers and also with periosteal reaction. So these are seen in HPUA and it is usually associated with squamous cell cancer. Squamous cell cancer. Fine. Now in the note that I have given you a small table like this, right? So go through the differences between small cell cancer and non-small cell. Non-small cell cancer can squamous, adeno, and something rare called bronchoalveolar carcinoma. So all of these are grouped as a non-small cell cancer. Then the differences are nicely given in this table. Okay, so please read them. This is for your reference. I've already told you one important feature of small cell cancer. It causes endocrine manifestations and other paraneoplastic, especially neuroendocrine paraneoplastic syndromes. That is a very important MCQ point. Small cell cancer, you get a lot of neuroendocrine paraneoplastic syndromes. I've already mentioned two. One is Cushing syndrome. Two is ectopic ACTH. Again, this is Cushing syndrome that we're talking about. And also a Lambert-Eaton myasthenic syndrome. That's a neurological paraneoplastic syndrome. It's called Lambert-Eaton myasthenic syndrome. And that is basically the reverse of myasthenia gravis. Reverse of myasthenia gravis. Where the muscles get weaker, muscles get stronger with activity. Muscles get stronger with activity. Okay. So small cell cancer, one important MCQ point you need to remember is it causes a lot of neuroendocrine manifestations. Okay. And also you can see another important difference. Radiotherapy is the treatment of choice for small cell cancers. Radiotherapy is a treatment of choice. Whereas in small cell cancer, it's a combination of chemotherapy and radiotherapy. But aching, you need to be able to study or identify this MCQ. So adenocarcinoma is basically a non-small cell cancer. It is common in females. So remember, squamous cell like tamai males are common. In females, it is adenocarcinoma. Horner syndrome is a feature of apical tumor. Yes, that's right. Small cell cancer presents with neuroendocrine, whatever I've told you, paraneoplastic manifestations. Clubbing is a feature of squamous cell. You get clubbing in most cancers, especially in squamous cell cancer. And what is the thing I just told you? A severe form of clubbing, which is also called HPOA, hypertrophic pulmonary osteoarthropathy, is a feature of squamous cell cancer. Radiotherapy is the primary modality for treatment of lung adenocarcinoma. So radiotherapy, remember, is mostly for squamous. Chemotherapy is better. It's actually a combination of chemotherapy and radiotherapy for adenocarcinoma. Okay. So that's about lung cancer. Now the last MCQ is something that you had asked me in your questions. Group. Okay. I've included some things that you had asked me during that, and if people had missed the answer that I gave, I put this again. Post-primary TB, aspergilloma is a cause for hemoptysis. That's right. So we have missed this during our discussion on TB. Aspergilloma is a fungal ball that forms in a TB cavity, and that can cause hemoptysis. So if a patient with TB comes with hemoptysis or history of TB comes with hemoptysis, you obviously have to think of a recurrence, yes, but you also have to think of an aspergilloma. Amphoric breath sounds kiyane amutu sound of breath sounds. It's a type of bronchial breathing that you hear over a cavity. So cavity ekaka sound. So in post-primary TB, you know you can get cavities and you hear bronchial breathing. I went through some of your answers. Most of you did not know the answer to the third one. Elevated vitamin D levels are a feature of post-primary TB. I'll tell you why. Because these granuloma secrete vitamin D. Okay, these granuloma secrete vitamin D. So TB as well as sarcoidosis, which is a very similar disease, can cause elevated vitamin D levels. Okay. What is the commonest extrapulmonary complication? It is not TB meningitis. It is probably pleural and lymph node TB, right? ඔය දෙක තමයි ගොඩක් වෙලාවට එන්නේ. Hyponatremia occurs, as you know, in any respiratory condition due to SIADH. So you know that any respiratory disease can cause SIADH. So make us something that I detected that I might not have covered last week about TB, some things that I have pulled out. Vajra, yes, so yes, it can cause hypercalcemia. So sometimes you see hypercalcemia in TB and in sarcoidosis. So that's true. You can get hypercalcemia in TB and in sarcoid. So make a note of that. That is a sort of a interesting thing that you think of. All right. So also now remember, ask other questions that you did not manage to find the answers to from the respiratory thing. Because you have covered everything except the clinical MCQs. Eva, you should be able to answer after your clinical appointments. Okay? I'm not going to waste time talking about those. This is easy, man. This is a Jatik MCQ. I think most of you have got the answer. This is nothing problematic. 21-year-old typical presentation. Usual story. There's a respiratory alkalosis on the blood gas with a very good CO2. So basically, the patient is hyperventilating. Right? Hyperventilating. Which is basically hyperventilating. But okay. I think all of you got this one. Most, at least this time the answers, most of you had submitted the answers and you had written very good answers for most of the questions. So that's very good. So we're making some good progress. I'll send you the marked things throughout the week. Okay. Last year weeks and this week's ones. So most of you did a very good job with this SCQ. Okay. So me, someone asked you differential diagnosis of dullness at the lung base. Okay, so some of the causes of dullness at the lung base are given in this slide. Consolidation, collapse, pleural thickness, and diaphragmatic paralysis. You can also include lung mass to this list as well. Lung mass to this list as well. Okay, so there are 1, 2, 3, 4, 5 causes of dullness at the lung base. Okay, and definitely we will discuss this in our clinical appointments. So I'm not going to waste time in talking about it, but you have written very nice answers about how to differentiate. And you can use general examination as well as the clear respiratory signs that I have listed in this slide. Okay, and most of you have written general examination signs as well. That's very good. For example, if you think of a lung mass, then general examination signs become more important. Okay? Things like clubbing and other features of malignancy. And so these are some of the things that you need to know. Okay, pleural thickness is a good differential diagnosis of a pleural effusion. Okay, pleural thickness is a very important differential diagnosis of a pleural effusion. Okay, exam case right? Okay, lasana katawa tamai, what you need to know is in a pleural thickness, okay, the vocal resonance is normal. Okay, it's just a thickened pleural and vocal resonance is normal. Percussion is not really stony dull, it's just dull. And the difference again, if you don't know, I will teach you when you come to clinicals. Okay, so the difference between pleural thickness and pleural effusion, stony dull, percussion on pleural effusion, pleural thickness, it is just dull. Okay, it is just dull. Okay, then then the next thing is the other thing is pleural effusion. The pleural effusion, the dullness extends up the back. If you visualize a pleural effusion, meniscus. So percussion in the axilla, say if it's at this level, percussion in the back will go higher than that. Now, percuss you will have a dullness ending somewhere. You can actually stimulate the meniscus. On the side, the percussion note will be somewhere here, whereas on the back it will be higher. So that's the difference. So these are the differences between pleural thickness and pleural effusion. Again, clinicals will be love to ask that question. How do you differentiate? So answer is percussion node will be going up the diaphragm higher on the back than on the sides. Vocal resonance will be reduced, and breath sounds eva මොකක්වත් අඩු වෙන්නේ නැහැ නේ pleural thickening එක. So you can write all of that. Okay? Right. Yes, Puri, you're right. We can't consider consolidation in this patient because this is a very nice whitish X-ray. But I'm just talking in general here. Okay. So yes, you can take lung fibrosis well, but unilateral lower zone only fibrosis is uncommon, but you can take that as well. No problem. So here, the differential diagnosis is between, in this patient, malignant pleural effusion. You have to write mesothelioma. Because mesothelioma looks exactly like a effusion on a chest X-ray. Exactly like an effusion on a chest X-ray. Okay. And in the history that this fellow worked in an asbestos plant. Okay. So you have to write mesothelioma for your differential diagnosis. Most of you had written that, and that's very good because you had noticed that in the history given. Okay. So asbestos mesothelioma is a pleural malignancy, which should always be considered in the differential diagnosis of a patient like this. Comes the pleural effusion like thing in the X-ray, and you need to consider that. Pleural, but you have to write mesothelioma, which is very important to write. Investigations, we discussed the investigations of this sort of patient last week also, and I think we have now solidified that knowledge in your heads. And what about pleural analysis, CT, basic investigations? So you had written that very well. Now the last question was confusion and seizures. And again, some of you had thought this out very nicely. Most of you had said, now this is a malignancy වගේ කතාවක් නේ malignancy වගේ කතාවක්. So some of you had written metastasis. Very correct. Metastasis වෙන්න පුළුවන්. Metastasis තිබිලා එකපාරට they might manifest. So metastasis is a good data, especially if there is bleeding into a metastasis. They suddenly get confused and start getting seizures. So most of you had written metastasis as an answer. High. Some of you have written things like carcinomatous meningitis and paraneoplastic syndromes. That is again accepted answer because remember malignancies can cause meningeal irritation and that can cause sort of a meningoencephalitis like picture, carcinomatous meningitis. And then malignancy can also present various types of paraneoplastic syndromes. Okay, that can cause fits and confusion. Some of you had written hyponatremia as an answer, which is a very good answer. Okay, because you know that malignancy again cancer can cause a malignant ascites. You don't call it a malignant ascites. It is a malignant cause for SIADH. Okay, because this tumor secrete ADH. Okay, so especially you see this in squamous cell cancer. Most of you had forgotten hyperthemia as an answer. Again, in squamous cell cancer, these squamous cell cancers produce parathyroid hormone related peptide, PTHRP, which is again a hormone that is secreted. Again, this is seen commonly in squamous cell cancer. Then squamous cell cancer ekata kiwwa katandarයක් that it causes HPOA, clubbing. Now you know two more things about squamous cell cancer, the odd manifestation. You know that it causes a malignancy related SIADH, and also it can cause secretion of a hormone called PTHRP. ගොඩක් අය ඒක ලියලා තිබුණේ නැහැ. සමහර අය hypercalcemia කියලා ලියලා තිබුණා, but this can secrete PTHRP and that can cause hypercalcemia. Another cause of hypercalcemia in malignancy is due to bone marrow metastasis. Bone marrow, when you get metastasis, it releases calcium and you get hypercalcemia. And why I'm focusing a little bit on hypercalcemia is if you don't look for it, you will never detect it. Sodium, but calcium is something very important to do in a patient with a malignancy coming with confusion and seizures, or suspected malignancy, confusion and seizures. You have to do the calcium, look for hypercalcemia. It's a medical emergency. Hypercalcemia is a medical emergency. So most of you had written some, or at least 4, at least 3. I think 100% of you have written 3 of these 5. I would have liked if you write in hypercalcemia and maybe explain how that happens, PTHRP or bone marrow metastasis with calcium release. Now, I'll answer two questions that you had asked about this. Can pleural biopsy? So yes, you can. When you're in, I'm sorry, I haven't mentioned that here. But yes, pleural fluid analysis, CT, basically, and pleural fluid analysis. You can also write pleural biopsy. And I think I told this to you last week as well. Pleural TB, which is one of the common causes of extrapulmonary TB, there is a 99% sensitivity specificity with a combination of pleural biopsy and adenosine deaminase. So if you have high adenosine deaminase, that's about 95% sensitive and specific, right? So you have a suspicious clinical syndrome, pleural effusion with ADA high, okay, ADA high, 95% sensitivity specificity. If you add the pleural biopsy, it is 99%. So very, very good predictive value, pleural biopsy. So if you think of even malignancy, you might see on a pleural biopsy with malignant infiltration, right? Can we consider rapid correction of the pleural effusion? That's a very good point. Yes, when you have massive pleural effusions and you aspirate it rapidly, you get something called re-expansion pulmonary edema. Okay, when you aspirate a pleural effusion very fast, okay, you get something called re-expansion pulmonary edema. Okay, and that causes a lot of shortness of breath and pulmonary edema, and also patient can go into shock and get seizures. You can write it, but it's less of a differential diagnosis in this particular condition. But there is something like that. If you aspirate a pleural effusion too fast, you can get something called, because the lungs are collapsed, it suddenly expands, and you get a re-expansion pulmonary edema. Purni, yes, delirium when puluang, but delirium is not a diagnosis, Purni. That is the point. Delirium is not a diagnosis. It always has a secondary cause. So delirium might be due to sodium, calcium. So it's always a secondary thing causing the delirium. So delirium is not a diagnosis. It is again a symptom. Right? Nishara, yes, hypercapnia. Yes, that's a reasonable answer. Yes, especially if the patient is a smoker, COPD, you can give hypercapnia as an answer for confusion as well. Okay, and I told this to you last week, COPD, one of the commonest cause of confusion in COPD patients is hypercapnia or the narcosis. I think that is it. Okay, so that is it. So, so today we have discussed a whole load of things about pleural disease, pulmonary vascular disease, and bronchial carcinoma. So pleural disease, we talked about pleural effusion. I gave you some important tables about causes, the Lights criteria. You need to know. Pneumothorax, we partially went through a diagnostic management algorithm for pneumothorax. Pulmonary embolism, how to diagnose, what the D-dimer is important in, Bell score, don't worry, we never discharge PE patients usually in Sri Lanka, but here they discharge so that they use the PESI score for mortality prediction. Then we talked about the management of PE and some of the X-ray and ECG changes that you see. Next, we went on to pulmonary hypertension, not a very common topic for undergraduates. Okay, so we talked about the causes, classification, some of the treatment options for pulmonary arterial hypertension, which is one of the categories. Then bronchial carcinoma, I revised some TB things with you, and then we went to the SCQ. Can we consider acid-base for? Yeah, but it doesn't cause a lot of confusion. Seizures again in the head. Can hypoglycemia occur as a paraneoplastic medullary lung cancer? Not that I know of. Hyperglycemia, something like Cushing's, but not hypoglycemia as far as I know. But you can get hypoglycemia in another way. Anybody just think about how that can happen? So hypoglycemia can occur if you, this is again very commonly seen in squamous cell cancer, where you have adrenal metastasis. Okay, so adrenal metastasis, where the cancer metastasizes to the adrenal gland. Okay, and then they can get adrenal insufficiency. Okay, and then develop hypoglycemia. because of adrenal. මම හිතන්නේ කවුරු හරි ඔයගොල්ලෝගේ MCQ එකක් අහලා තිබ්බ about a TB story with Addison like කතන්දරේ. Addison වල you know hypotension, low sodium, high potassium, low glucose. So you remember you can get Addison second to bronchial cancer because of adrenal metastasis, and you can get Addison second to TB because it can cause TB adrenalitis. So here my best of 5 MCQ එකක් මම දැක්ක කවුරු හරි අහලා තියෙනවා in your group story case summary of a patient with adrenal with TB, and then a sort of low sodium high potassium picture like a adrenal disease, and then you get adrenal insufficiency in TB due to TB adrenalitis. That is another identified. Okay, the SCQ we have discussed now, no problem. I think that should be fine, and I'll give you feedback over the next week about your answers. Right, any other questions from the respiratory system? Now we have discussed asthma, COPD, interstitial lung disease on the first day. Second day we talked about pneumonia, bronchiectasis, lung abscess, TB. Okay. Then today we discussed about pulmonary hypertension, pulmonary embolism, pleural disease, and bronchial cancer. So that's basically the whole of. I probably have not discussed obstructive sleep apnea. I'll probably do that later. That's also considered to be a respiratory topic. We just do a little bit of that maybe next week. Right. Any questions from past papers that you want to ask? What is the commonest type of lung cancer in Sri Lanka? I think it's still squamous cell cancer, but please refer some where may ලංකාවේ තියෙනනේ මේ epidemiology unit එකෙන් statistics වගේ එක පොඩ්ඩක් බලන්න, but I think it's usually squamous still. Should be. But remember the adenocarcinoma rates are going up, but I think it's still a squamous that is the commonest. Past paper MCQs you want to ask? Type කරන්න බැරි නම් mic එක on කරලා හරි අහන්න. පුළුවන් mic එක on කරන්න ඕගොල්ලෝ. If you have any questions, past paper related questions. Nishara?
නැතුව ඇති
ප්‍රශ්න නැහැ ඔක්කොම දන්න.
නෑ ගොඩක් ඒවස chat එකේ අහනවානේ.
අහලා තිබ්බනේ. ධනංජය මතනේ pleural accumulation. Is there pleural fluid accumulation? Is that considered? Yeah. So, metana, in this case, yeah, that's a bit of a lateral thinking, but you might get a few marks for that. Now, I'll tell you, සාමාන්‍යයෙන් අපි exam papers mark කරනකොට, they are marked in, there are various ways to mark these papers in. Then we make a marking scheme, like A level වල කරනවා වගේ marking scheme එකක් හදලා ඒකට ලකුණු දෙනවා. But sometimes when students have written reasonable answers, we give marks for those as well. The marking scheme එකට තිතට හරියන්නේ නැහැ. ඒ level එකත් mark කරනකොට එහෙමනේ. සමහර ළමයි examination නොහිතපු දේවල් ලියනකොට we can consider how much marks to give for those. So if you have written some rational thing which can be given marks, don't worry. එක marking scheme එකේ තිබුණා නැහැ කියලා නෑ. We will give you marks for those. So it's very fair. Okay. Sometimes you mark these something called conference marking. කොමල එකට වාඩි වෙලා බලන වෙලාවලදී then of course these can be discussed then and there between the panel of examiners and then given marks. Saroj, can you tell about bronchoscopy in bronchial carcinoma? I don't think it's very important. Bronchoscopy thing කරනවා for to get a tissue diagnosis. Right? I don't think for an undergraduate future දැනගන්න ඕනේ නැහැ. Sajana, HPO is commonly adenocarcinoma. I'll check on that. I'm not sure whether that's right. I'll check on that and let you know on the group. If when there are effusions in you, does it make a particular organism likely? No, Gimhan, no. Kirtika, you can get cavernous breathing. Cavernous breathing is again a cavity-related type of bronchial breathing. Amphoric, cavernous, they come in the pulva. So almost the sounds almost the same. Actually. Right. Okay then.